So we have three speakers today, which is great. And I'll just start with some introductions. So Mohsin Sadat is a medical doctor specialized in public health with the Masters of Science in Infectious Diseases. He works at University Eduardo Mondlane, teaching undergraduate medical students and postgraduate students, both in the master's and PhD programs. His work is related to epidemiology of infectious diseases, mainly HIV, and chronic non-transmissible diseases, mainly cancer, medical education, health systems, and implementation science research. So welcome. Uh, we also have Yolinda Montero, uh, a pediatric gastroenterologist at Maputo Central Hospital in Mozambique. She completed her medical degree at the Faculty of Medicine at Eduardo Mondlane University and her specialist training in pediatrics at Maputo Central Hospital. Her subspecialty training in pediatric gastroenterology was conducted at Pontificia Universidade Católica do Rio Grande do Sul, São Lucas Hospital in Brazil, and Stellenbosch University, Tigerberg Hospital in South Africa. So welcome. And then Chris Buck is an associate professor of pediatrics at UCLA and lead for DGOSOM Global Health Partnership Program Partnerships in Mozambique, Brazil, KwaZulu-Natal, South Africa. He does his clinical and teaching work on infant ward at Hospital Central Maputo and leads a pediatric clinical research unit in collaboration with Universidade Eduardo Mondlane School of Medicine. He has a master's in public health and a member of Mozambique Ministry of Health technical working groups for pediatric HIV and TB. So welcome. So I will hand it over to the three of you to get us started.
Thanks so much for the introductions, Joshua, and good job with the Portuguese there. Um, really happy to be joining you guys all today. We had this same partner conversation last year with a focus on medical education in Mozambique, and we had a really interesting discussion last year. Dr. Sidat was with us last year, and we've substituted in Yolanda this year. I think her background and her perspective is going to be very interesting for everybody. So yeah, just for them to know their audience, Joshua, could you tell them roughly, could you tell them just briefly about the students who are participating and who they're lecturing, who they'll be speaking with?
Yeah, so I think almost all of us, if not all of us, are first year medical students, just 2 months into our training, um, all with an interest in global health by being here, by nature of being here. Yeah.
And we have
Great.
two MS3s as well that have joined the course. So sometimes people are not able to fit it in their first year of medical school, and so if they have a gap year or a discovery year that has some flexibility, they join then. And I see Jonah's camera's on. That's one person that is an MS3.
Great, thanks. I wanted to let you know I also invited members of our, we have a pediatric research team here in Mozambique, and a lot of them are interested in more broadly in the partnership between UCLA and Mozambique. So there's other members from our team who are on the call, and say welcome to all of them. And yeah, hi guys. So Dr. Sidat was very humble in his bio that he shared. But I wanted you guys let you know that he was just recently promoted to be the vice rector for the entire university, UEM, which is the largest public university in the country, and a really big position, and a position where he's going to have a lot of influence on not just medical education, but more broadly, higher education in Mozambique. So I think it's really timely that he's here with us today to speak about this. So what we're thinking about doing is I wanted to start with a little bit of a conversation with Yolanda, and for you guys to hear a little bit about her experience. And then that, I think, will be a good introduction to then a talk that Dr. Sidat has prepared about medical education in Mozambique and what are some of our challenges and our opportunities. So with that, I think I'm going to go ahead and start with you, Yolanda. And by the way, I have to say thank you to Yolanda. She's doing night in the pediatric ICU tonight, and normally she's resting up and taking a nap right now, but she was really gracious and agreed to participate in this. So thank you to you, Yolanda, for being a part of this.
No problem. It's a pleasure. Thank you for inviting me to be part of this talk. And just want to apologize for my voice because I have a bit of a flu since yesterday. I hope you can hear me well.
We can hear you fine, and thanks again. So, your bio touched on the journey you've taken through your medical education. But please kind of walk us through it, from the time you finished high school. In the United States, people do university after high school before they can go to medical school. And that's different in Mozambique. So will you just walk us through how you went from being a high school graduate in Maputo to being a pediatric gastroenterologist in Mozambique?
Yes. After I finished high school, when we finished high school, right afterwards, we applied for Eduardo Mondlane University, and I did apply for the Faculty of Medicine, and I got in. I passed the exam. So literally, I finished the high school, and a few months later, I was starting medical school. So
How old were you? 18?
sorry,
How old were you at that time? 18 years old?
I was still 17.
Mhm.
I was going to turn 18 a few months, I think 4 months later, 4 months after I started med school. So I wasn't 18 yet. Yes.
Okay.
Yes, exactly. So it was a bit of a shock because I was used to this high school education, and then the med school is quite different. So it was a shock in the beginning, but of course, with time you get used to it, and you learn to adapt and learn and know how to how to be a med student. But in the beginning, it's a shock because it's completely different. But I must say that in my time when I did med school, there was a lot of support for the medical students. We had at that time, we had Mozambican professors, we had other professors from other countries that came also to help us. So that made a huge difference. And also I had another challenge because they changed the curriculum. I think in the second year, they decided to change a bit the curriculum, and then we had to learn topics from 1 year in a few months, just to adjust to the new curriculum. So we had also that challenge, but well, we were able to survive to that. Because when I started, it was supposed to be 7 years of med school, and then they changed it to 6 years. So we had to learn everything in a shorter time. But we did
We're having a brief cut in your internet there, Yolanda. Can you still hear us?
we managed it. I think that when it starts, I mean, the intern.
Sorry, guys, this is one of the realities with calls in Mozambique. Yolanda, you're
Sorry.
back. That's okay.
Yes, I'm back. Sorry.
No
Yes, that
worries.
was a temporary glitch. Yes.
So you were telling
So
us that you had a new curriculum that you guys adjusted from 7 to 6 years. And how do those 6
yes.
years go? How many of those are preclinical? How many of those are clinical?
So those were 2 years. 2 years. I think it's 4 years because in the third year we started doing clinicals. Yes, from the third year until the sixth. Yes, until internship. So it's different, but also we had a lot of support when we started the clinicals, because we had this we had the Mozambican professors, tutors during clinicals, but also we had Cuban teachers that came also to help with this transition from the new curriculum. So we had assistants throughout the clinicals, so we're not left alone, and that's really made a huge difference. So of course we had challenges. Of course we had challenges because I don't know how it is in US, but we have a huge. I mean, the class we have. There was quite a huge number of students, and sometimes there can be a challenge to the teachers. But yeah, I think that
Let me ask you
needs.
another question. So I'm sorry,
Yes,
I
you
didn't
have to.
there was a slight delay. I
Okay.
wanted to ask you, in Mozambique, it's not obligatory to do residency after medical school. At what point during your training did you know that you wanted to pursue a career in pediatrics? And how did you transition from medical school to a pediatric residency?
So after I finished med school, I went to work in this district in Inhambane province. I worked there for 2 years, and I was responsible for the pediatrics ward. So that's when I decided that I wanted to do pediatrics, because I was responsible to see the children, and then my passion for pediatrics grew at that point. So I worked in the district for 2 years in a rural hospital, and then applied to pediatrics residency. So then that was the transition. So I worked as a medical doctor in a district, and I was the medical chief doctor as well. That was a challenge because there is much administrative role there. It's not only seeing the patients, but dealing with everything else, with the supplies, with the vaccination campaigns, and going to the community. And so also that was, a challenge, because, you are trained to be a medical doctor just to see patients, and then you have to take care of the whole district. And I was responsible for the rural hospital, also responsible for another 10 health centers in the district. So I had to go and supervise all of them. Also, that was the rural hospital was also the referral hospital for another 3 districts in the north of the province. So that was also a huge challenge, but I mean, I think that made a huge difference in the way, even in my daily practice as a doctor, that makes a huge difference to see how is the health community, and how things work, the vaccination and stuff like that. So that's how it was.
So because of this, guys at UCLA, for you to know, so because they come straight out of high school, often the medical students are younger and less experienced than medical students in the US, but because many people actually are required to do work after medical school before they're eligible for residencies, often the reverse is true of residents in Mozambique, that they're folks who have more work experience than in the US. So Yolanda, you got admitted to pediatrics residency, and most of the residencies in Mozambique are in Maputo at the Central Hospital. For how long did you train? And at what point did you decide that you wanted to become a pediatric gastroenterologist?
Yes, I trained for 6 years. The training is for 4 years, but I think I took 5.5 years, because, of course, through residency, you have this program, and we always try to follow the program. But sometimes, if you need staff in a certain ward, then you will stop following your program, and then you have to help in that ward. So that's why sometimes we take a little bit longer. It should be 4 years, but sometimes we take a little bit longer. But I think I took 5.5 years of residency in pediatrics. And I think I was in my second year of residency when I went to UCLA. and I had the opportunity to see how is the pediatric residency there. Of course, I saw some differences. I think in terms of teaching at UCLA, it was better. It was a bit more organized because the residents were having it was in the afternoon. Almost every single day they had these sessions with the specialists. So the specialist would come to teach something, or one of the residents would present a topic, but always with a specialist. So I think the difference is that in terms of teaching, I felt that it was more organized there than in Mozambique. Yeah.
Thanks, Yolanda. I think folks in the States would be shocked to know that residency can go longer than the organized period. In the States, you sign up and if you do all your rotations, you'll be done in a set number of years. But guys, in Mozambique, it's not like that. And it's one of the big challenges, I think, is residents can get stuck asking to repeat rotations for staffing
Yes.
reasons. So residency can be quite a prolonged journey, and you're doing nights, you're doing weekends. And it's something I'm not sure I would have signed up for had I been here at this point in my training. Yolanda, just to Tracy, I see your question. Yolanda, are you paid during residency? Tracy was asking.
Yes, we are paid.
Yeah. So just for sake of time, I'm going to keep moving us along. So you mentioned you had a chance to go to UCLA for 2 months during
Yes.
your residency experience. And then when you decided you wanted to do pediatric gastroenterology, and by the way, everybody, Yolanda, you're talking with the first and only Mozambican pediatric gastroenterologist. So it's pretty cool. When we talk about pediatric GI in Mozambique, you're looking at it right here, Dr. Montero. But
Thank you.
Yolanda, tell me about the experience you had training in Brazil and in South Africa, and why that was actually necessary, because as I mentioned, there was no one else here, no other pediatric GI doctors to train you. So tell us a little bit about that.
Yes. After I finished the pediatric residency, I was supposed to go back and work in another district hospital. And then that's when I decided maybe, actually there was this opportunity to do short course training in any area. So one of my tutors said, we don't have a pediatric gastroenterology. Maybe you can take this opportunity because this was an opportunity for for health workers of the Ministry of Health. So she said, maybe you can try pediatric gastroenterologist because we don't have any GI doctor here in Mozambique. So that's how I ended up in Rio Grande do Sul. So then I stayed there for almost a year. I didn't have that much idea of what pediatric gastroenterology means, because we don't have a GI doctor, and so you don't have this rotation through your residency. So there, the training was really good. I had really good tutors. I think that's where I fell in love with pediatric gastroenterologists. I just wanted to be like them because there was a lot of teaching. I learned a lot of things, and so I definitely said to myself, this is what I want to do. So unfortunately, it was a short course. It wasn't an official residency, fellowship program. So I had to go back to Mozambique. So I did want to finish my training. So I did find I did get the opportunity to go to the Stellenbosch University Tygerberg Hospital. Unfortunately, I had to start from zero because it's a different program in another country. So, but I took the chance, and then I went to South Africa to do the fellowship in pediatric gastroenterology. That's how my journey was. But I think that it was good for me because I had different experiences with the same subspecialty. In Brazil, you have I mean, it's a bit similar to Mozambique, but I think that the pathologies in South Africa were more similar to what we have here. So what I saw during my training in South Africa is exactly the same. It's the same it's the same pattern that I see here in Mozambique. So that was a big. I think it was good for me at the end. And although it took more time, but that means that you learn more and you have different experiences, yeah, in different countries. Yeah.
Yolanda, I'm seeing the time. I wish we had 2 hours so I could hear more from you and more from Mohsen, but I'm going to ask you one last question and just ask you to briefly respond. But you've had not many people have been able to train in as many different places as you have. You've trained in 4 different countries if you include the time you spent in UCLA. And I'm sure over that time you saw teachers and had professors and mentors who you thought were really effective teachers. And so I would just say kind of, what did you take from all these experiences that you use now as an educator? You work in a teaching hospital and you work with medical students and residents. So what did you learn? What's your teaching style and how do you try to be effective as an educator?
Well, as you said, I've had different experiences, mentors that are more prone to teach, and they have the patience to teach, and they know how to engage you in the teaching. So what I try to do, the method, I try to follow up the style from the mentors that I look up to, because all of my mentors in Brazil, they were the 4 of them. Sorry, the 4 of them, they're all good mentors. They love to teach, and they all and I learned from all of them. So I try to follow that style with the medical students, with the residents here in Mozambique, because I think that have to try to engage the students. Yeah, you have to try to see that how wonderful medicine is, how wonderful it is to take care of the patient, and how if you have knowledge, it's far more easier to take care of the patient. So it's not like, oh, I have to study because I have to study. No, if you study, you have more knowledge and you will take better care of your patients. So that makes everything easier, because it's not like you're struggling. It's like I'm reading a novel, a romance, and you're just absorbing and absorbing. So I try to send that message, and doesn't have to, of course, medical school, I don't think it's supposed to be easy, but it doesn't have to be that bad. So
That's
yeah.
a great point. Guys, Yolanda is somebody, and she won't say this about herself, but she's somebody, and unfortunately not everybody here has this perspective, but she is a kind and respectful person. She knows that people learn well when they're comfortable, and she's a good colleague. So I'm really excited. We're starting a clinical trial soon, and we're gonna have a chance to I'm gonna have a chance to continue my work with Yolanda in a different way. She's gonna be our hospital representative for this clinical trial. And so we're going to get to work together in the research arena. So Yolanda, thank you so much. Like I said, I wish we had more time to hear from you. And at the end, if there's time for questions, if you're able to stay on, maybe the students will want to ask you something. But if you need to go because of your night duty, I also understand. And
Okay.
with that, Dr. Sadat, I think Yolanda gave us a great intro into kind of what the journey through medical education is like in Mozambique, at least for someone who ends up as a subspecialist. She touched on, but didn't get into a lot of detail about some of our challenges. And I think it would be great now to hear from you and your perspective as a medical educator and former dean of the medical school and now vice rector of the university. So I'll turn it over to you, Dr. Sadat, and please try to wrap up by at least, leave at least 5 minutes at the end for questions if possible.
Hi, good morning to all in US and good afternoon to all here in Mozambique. First, I'm very pleased and honored to be here in this talk and I would like to thank Chris for inviting me again. Um, I think Yolanda spoke about almost, or maybe most of the things I was going to speak, but can I show my slides? Can I share my slides? So I can give some background.
Yes, absolutely. I think you can just click on the share button.
Okay, thank you. So where is the point?
We can see your mouse moving, Mohsen.
Yeah. Okay, thanks. So just some pictures of our medical school at UEM, but I'm going to repeat some of the things I talked about last time, but very briefly, just to give an overview about Mozambique. We are about 33 million people. Mozambique is considered a low-income country, and the Human Development Index, you can see, is quite low compared to other countries. Some of the factors that contribute for this are poverty, inequality, limited access to services. Here, we can include health services, but also education. We also have some problems with terrorism in northern part of the country, and Mozambique is very prone to climate-related events, so we also have some of the problems. Our burden of disease is characterized by infectious diseases, which are still significant, but mainly among children. But we are also facing now progressive increase in non-communicable diseases. Our burden is once again related to poor sanitation, unsafe water, malnutrition, and in Mozambique we see both undernutrition and also some tendency, particularly in urban areas, for increased weight or obesity. We are prone to climate. We have periodic issues related to floods, drought, and cyclones, and our health system is considered somehow weak. Just for you to have an idea, our health infrastructure only covers about 45% of our population, and if we take in account community health workers, then our health services coverage increases to about 60%. So about 40% of our population have to travel long distances to have access to health services. So they don't have easily access to health services. In terms of health professionals, since independence in 1975, Mozambique has been investing a lot in training health workers, and gradually the situation of health workers is improving. Currently, our ratios are still below what is recommended by WHO for Africa, but still we have shortages of medical doctors, dentists, and nurses and other professionals. The map here of Mozambique shows that the distribution of health workers is not equal along the country. So we've also faced inequity in terms of not only access to health, but also access to health professionals. So I'm going to run a bit, but if you have questions, you can ask me again.
Just for comparison, I just want to let everybody know, I think the number of doctors per 10,000 in the US is approximately 31.8. So to compare that to what he
Yes,
showed,
so
0.8 compared to
0.8, so even less than 1 per 10,000. But you can see the improvement from 2011 up to now, and I'll let you know in this next slide why. So until 70, let's say, until 2000. So UEM is the first medical school in Mozambique. It was established in 1962, 1963, okay, and is located in the capital here. And until around 2000, it was the only medical school in the country. After until 1994, we only had one party. From independence to 1994, Mozambique was governed by only one single party. After that, the constitution changed, and we start having change also in policies from a communist perspective to more liberal, open market perspective. And this allowed also for not only health private sector to come in, but also private education institutions to also establish. And this happened not only at primary and secondary level, but also at higher education level. So from 1994, we started having new universities, but it was after 2000 that we start having first graduates, medical graduates from other universities that were established. And I highlighted some of them here. So currently we have four more, we have three more public, actually four, because there's a new one in Kliman. So four, a part of UM, we have four more public universities, and we have three private medical schools. Maybe very soon, five. I'm not sure about if these new institutions are already operational or not, but there are two that will start working very soon. The medical schools, they only the training is only focused on I don't know in US what they call, but in our context we call licentiates, meaning that for the post graduation, like specialization, they need to enroll in a different program, as Yolanda also explained very well. But we can discuss again if it's needed. Currently, there are more than 50 private higher education institutions, so you can see the change.
Awesome. I'm
Yes.
sorry, before you go to the next slide, clearly Mozambique needs to massify medical education with our doctor to patient ratios and the health challenges of the country. But, with our limited resources, decentralization and maintenance of quality, and, to ensure that new medical schools have adequate tutors who are qualified. And I imagine that's a big concern. Is it something you could speak to really quickly, or is that in a future slide?
Yes, I have included in one of the
Okay, sorry.
next
Please
slides
continue.
when I speak about some of the challenges. But that's a good point, Chris. Thank you. So this is what happened. I'm not going to bother you a lot with this slide, but just to say that since 1995, we have several changes in the curriculum. We started with a 6-year curriculum after independence, back to 7-year from 1980s to mid 1990s. Then again, we had a curriculum revised still for 7 years. In 2004, we reduced for 6 years. This is a curriculum that was inspired in the Cuban model. And between 2008 and 2012, we tried a new system based on a Netherlands way of training, like PBL, problem-based learning. This curriculum was not that successful, so we went back to the previous curriculum of 6 years. And I'll explain here how our curriculum is structured. I think Yolanda also said something about this. So students who complete class 12 or equivalent They, sit for national exams. We have common exam now for all public institutions that are offering medical degree, and some institutions that are also offering other health courses. So for the medical degree, they have to do entry exam on chemistry and biology, and depending on the vacancies, number of vacancies, the best who get good marks, they enter the medical school. So, for example, for UEM, we have around 3,000 applications, students from all across the country, from Maputo to Rovuma, as we say. And to be more equitative, to be, just we have quotas for the provinces, because the trainees from Maputo and some of the capitals, they are better qualified, and usually they have better marks to get in chemistry and biology. But we also reserved some quotas for each province. So there is currently 2 to 3 vacancies for each province. So from 90 vacancies that we open now, 90 places for about 3,000 applicants, we have 50%, which is about 50 vacancies from Maputo city and province, and then we have about 2 to 3 vacancies for other provinces. So once they get to the medical school, the medical course in the medical training in our university, and most public universities follow the same pattern or same path. They have the first 2 years that we call basic science years, and then we have clinical science. So in the basic science, we have basic disciplines like anatomy, biochemistry, histopathology, histology and pathology, physiology, etc. All genetics, immunology, microbiology, some public health related subjects like epidemiology, biostatistics, etc. Then once they complete 2 years, they have to have all subjects completed before they can transit to the clinical cycle or clinical sciences, and they will spend third, fourth, and fifth year in clinical sciences. And here we have all clinical sciences, including, internal medicine, pediatrics, gynecobstetrics, surgery, and other disciplines like ENT, ophthalmology, and other, clinical sciences. And once they complete, they do what we call the integrated training, which is like a professionalization, like internship. And during this period, the students actually only have practical training. They very rarely they have theoretical classes, but they can have, depending on the services where they do the training, they might have some theoretical sessions. So in this integrated training, they have 5 main areas, which are internal medicine, surgery, gynecobstetrics, pediatrics, and primary healthcare practice. We used to have primary healthcare practice linked with rural practice, so allowing students to be exposed to the rural context, to the challenges that we have in peripheries, in remote areas. But due to many constraints, particularly logistics, we are now not sending our students to rural areas, but we are sending our students to primary health facilities in and around Maputo. Once they complete the training, 6 years, when they pass, they have to sit for exam to be registered in Medical Council, Mozambican Medical Council. Once they are registered, they can apply for vacancies in the National Health Service, or they can also opt to work in any other clinical area or work in wherever they want. They are free. This was changed in 2017. Before, every graduate had to work at least 2 years compulsory in the country, and the admission of our graduates was automatic. But now, because there are about 250 to 300 graduates every year from different universities, the Ministry of Health has some constraints to absorb all graduates because of budget issues. So they opted to now open vacancies, and graduates need to compete. Those that pass, the process that they are in place for admission, administrative and curriculum and other procedures, they are admitted to the National Health Service. Many people now apply for NGOs, private clinics. They do also apply for higher education institutions to work as a teacher or trainers, etc. This slide I only brought because of the issue of retention within National Health Service, where it shows that although this study is a bit old, 2012, this was done at a time when all graduates usually were admitted automatically to the public service, public sector. And you can see about 25% of graduates used to leave the public sector. Some of them, very, very few, migrated to go. They went abroad. Most they stayed in the country and seek work in NGOs or other agencies, and some of them, very few, worked in private sector. Our private sector, which also started after independence from 1975 to 1994, it was interrupted, but 1994 it was again allowed, and the practice is the private practice sector is still very scarce or is not well developed. They are mainly concentrated in the main cities, particularly in Maputo, and their capacity to absorb graduates is still very limited. So you don't see many opportunities for graduates to go and work in private sector. Although I see now emergence of small clinics all around the country. I'm not sure if these are joint ventures or joint initiatives between clinicians that are coming from universities, new graduates, or this is mainly initiatives from specialists. I think maybe
Nelson,
we
I
will
think
need to.
this is
Yes, yes.
this is an important enough point that I want to interrupt you. Sorry, and ask this question, but the fact that the Ministry of Health doesn't have the capacity to absorb all the graduates that these medical schools that you showed us are putting out is inherently problematic, right? And the last thing a country like Mozambique needs is unemployed young doctors who are graduated and can't find work.
Yes.
What is the solution for that? And it might not be an easy, short answer.
Yes. Well, one of the things I tried to do when I was dean in 2017, when they started this system, was to insist with the Ministry of Health to keep 2-year compulsory service and allow with contract, with salary, and allow clinicians that are coming from the system to work. I mean, from the universities to work in the system and improve also their skills and implement a system of rotation. After 2 years, then they would, be allowed to compete for vacancies. So I was trying to advocate for vacancies, admission through vacancies after 2 years of service in the system. Unfortunately, I didn't manage because the country and this happened after the scandals corruption issue, the issue of debt that the government created. So after 2017, the country is facing considerable issue with overall government budget. Solution. My concern or my worry was to lose, graduates that are, every student goes to the medical school to be a clinician, and they dream about becoming doctors that are caring for patients, etc. And I was concerned that this was going to frustrate many doctors, so they won't be able to continue. I think there are issues that the government need to think, innovative issues, such as, for example, because there is another issue, that if you don't have good doctors, general practitioners coming to the system, we will also struggle to have good candidates for specialization. And so I think government needs to think about incentive systems that attract doctors to come at least work a few years, and those that show interest in specialization, allow them to specialize and have good critical mass. Um, I don't know how they are going to solve the problem of availability of budget, but I think they need to prioritize this, because otherwise the National Health Service will suffer in mid long term
Thanks
with
so
this
much.
issue.
Sorry to interject there, but I really wanted to explore that. I know probably about 5 more minutes, so choose your most important points, and then we'll let
Yes.
open it up for questions.
I have two more slides. I tried to summarize. So some of the challenges, as you mentioned, Chris, expansion of medical trainings is a big issue, particularly with scarce qualified academic staff. Mainly specialists are in the main cities, particularly in Maputo, and the other provinces are still struggling with attracting and retaining specialists. So because of that, also the medical schools that are outside Maputo, they are struggling with access to qualified academic staff. Another issue is that all medical schools that are coming, they don't have their own hospital, dedicated hospital. They are trying to use public hospitals, including private medical schools. And this is creating a considerable problem, overcrowding of hospitals with graduates from different institutions, including other health allied training institutions. So this is also a big problem. Our agency for quality assurance and accreditation, they don't have qualified staff for specialized in medical education. They have people who are very qualified to assess, higher education training, but not specific to medical education. So many schools or medical schools that are that were approved, perhaps with more qualified health personnel who can look at specific medical training issues, they won't be approved. They won't be authorized. They wouldn't be authorized in normal circumstances. But this issue is now being resolved, or they are trying to resolve. They have just indicated a national committee where they recruited some people from different institutions, medical institutions with experience in medical education, and also members of medical council, to try to figure out kind of model curriculum and model infrastructure and resources that medical schools require for medical training to be authorized. Okay, let's move. Opportunities. I just wrote this slide now, and one of the things that came to my mind was that Eduardo Mondlane, for example, and I believe other universities as well in Mozambique, they have 5% of vacancies for international students, and we like at medical school at UEM, we are having students coming from Tanzania, for example, East Timor, and other African Portuguese-speaking countries. So this is one, but we also have students coming from other countries. They have to compete for exams unless these students come through agreements, like in Tanzania, students coming from Tanzania and East Timor, they come through agreements. Um, Another opportunity or good thing about medical education in Mozambique is that our students have opportunity to practice hands-on, and also they are exposed to diversity of tropical diseases like infectious diseases that are predominant in the country, but they're also exposed to NCDs and other climate and poverty-related diseases. As I mentioned, we have a strong practical component. Of course, that if you have, you know, wards or hospitals crowded with students coming from different institutions and from different courses, this becomes quite challenging. But a decade ago, for example, or a little bit more, we were very few, and we had so many patients to look after, and we had so much opportunities to actually also learn by practicing. Of course, that we are also trying to overcome the current challenges by establishing, what we call simulation training centers, where we can train students and also ensure that students, before they go to the real practice world, they become competent or skilled, and understand the risks and precautions they need to take when they are facing real patients. We also expose our students to some national programs and some managerial issues. Many of our students, when they enter the National Health Service, they actually also are indicated to assume leading positions. So they also have to have some managerial skills. Well, thank you very much. Apologies for extending a bit my talk, but I welcome questions and
Thanks, Mohsen. If I hadn't
comments.
been interrupting you, you would have been right on time. So great
Yeah.
work.
No
Um,
problem.
I think, guys, I'll just say from my perspective, representing the Global Health Program in UCLA, I'm really proud of our role here, supporting UEM and supporting Hospital Central and their efforts for medical education. I think Yolanda and Mohsen both touched on some of the challenges, but I've got a lot of junior medical doctors on our research team who are here on this call. And Yolanda, they're testament to the fact that despite the challenges, Mozambique is producing excellent physicians and folks who are quickly having to assume leadership roles, things that in the United States come at a later point in your career. So there's young people here, as Yolanda mentioned, right out of medical school, she was the district, head medical doctor. That doesn't happen in the US. So it's really impressive when you're here and working to see how people are put into positions of leadership and have to grow really quickly beyond their clinical education. So we have 2 minutes left. If there are any questions, someone please raise their hand, or you can put something in the chat. Dr. Sidat's son is on this call, and I dared him to ask his dad a difficult question, but I doubt he'll do so. But does anybody have a question either for Yolanda or for Dr. Sidat?
I have a question for Dr. Yolanda. Since you're the only pediatric gastroenterologist in Mozambique, how are you thinking about expanding the fields locally and inspiring others to enter the specialty?
That's a good question. Actually, it's a challenge being the first one because you have to start from the ground. So the thing is, first I'll give a practical example. I need to do scopes, and currently I'm doing the scopes in the adult GI theater. So now we are trying to have our own theater in the pediatrics department. So that's one of the challenges. And hopefully soon we'll have our own theater, so we can do the scopes in the same building as the pediatrics department. So everything I have to start from the ground. And at the same time, I have to try to convince the pediatric residents who are in their last 3 year of training, if they want to do the fellowship in pediatric gastroenterology. But I think that currently they're not rotating to GI because I recently started working. But I think as soon as they start rotating to GI, they will see I'll have more chance to show them what pediatric gastroenterology means and try to convince them, because being the only one, it will make things harder, more difficult. But if as soon as I have more medical doctors specializing, that will be easier to expand. But of course, nonetheless, I'm doing everything I can to try to expand, and hopefully
I think a lot of you guys will see your first year med students, but the folks that you encounter as mentors during these 4 years will have a big influence on what areas you become interested in. You know, there were specialties I was interested in that I went away from because I had bad experiences in the clinical setting, and vice versa. There was things that I got drawn to simply because I had a really dynamic, positive leader who was teaching me. And I suspect that's what's going to happen with Peds GI once Yolanda gets established with her rotation. So, guys, I wish we had more time for questions. We're past the hour. Please, everybody, make sure to fill out the evaluation. Elizabeth put the link in the chat. Also, part of this session was for me to generate interest in Mozambique as you guys navigate your med school career. So we hope to see some of you guys in Maputo, either for discovery experience, research, or for your 4th year clinical electives down the road. And feel free to reach out to me individually if you have any questions. Let's all give Mohsen and Yolanda a round of applause. Thank you guys both very much.
Thank you.
And have a nice day.
Thank you very much.
Thank you.
Thanks.